Hello, welcome back to a lesson about brachial palsy. Brachial plexus injury is a common problem with an incidence of 0.6 to 4.6 per 1000 live births. Injury to the brachial plexus might cause paralysis of the upper part of the arm, with or without paralysis of the forearm or hand, or more often paralysis of the entire arm. These injuries occur in macrosomic infants and when lateral traction is exerted on the head and the neck during delivery of the shoulder in a vertex presentation, or when the arms are extended over the head in a bridge presentation, and sometimes also when excessive traction is placed on the shoulders. Approximately 45% of brachial plexus injuries are associated with shoulder dystocia. There are two types of brachial injury. The first one is Erb's paralysis. In Erb's paralysis, the injury is limited to the fifth and the sixth cervical nerves, and the infant loses the power to abduct the arm from the shoulder, rotate the arm externally, and supinate the forearm. The characteristic position consists of adduction and internal rotation of the arm with pronation of the forearm. Power to extend the forearm is retained, but the biceps reflex is absent and the moro reflex is absent on the affected side. The outer aspect of the arm may have some sensory impairment, and the power in the forearm and hand grasp is preserved unless the lower part of the plexus is also injured. The presence of hand grasp is a favorable prognostic sign. When the injury includes the phrenic nerve, alteration in diaphragmatic excursion might be observed with ultrasonography, fluoroscope, or asymmetric elevation of the diaphragm on chest radiograph. The other is Klumpke's paralysis. Klumpke paralysis is a rare form of brachial palsy in which the injury to the 7th and the 8th cervical nerves and the first thoracic nerves produce a paralyzed hand. Ipsilateral ptosis and meiosis, sometimes called Horner syndrome, if the sympathetic fibers of the first thoracic root also affected, can happen. Mild cases may not be detected immediately after birth, and differentiation must be made from cerebral injury, from fracture, dislocation or epiphyseal separation of the humerus, and from fracture of the clavicle. MRI demonstrates nerve root rupture or avulsion if done in the case of Klumpke's paralysis. Regarding treatment consists of initial conservative management with monthly follow-up and a decision for surgical intervention by 3 months if function has not improved. Partial immobilization and appropriate positioning are used to prevent the development of contracture. In upper arm paralysis, the arm should be abducted 90 degrees with external rotation at the shoulder, full supination of the forearm, and slight extension of the wrist with the palm turned towards the face. This position might be achieved with a brace or splint during the first 1 to 2 weeks of life. Immobilization should be intermittent throughout the day while the infant is asleep and between feedings. In lower arm or hand paralysis, the wrist should be splinted in a neutral position and padding placed in the first. When the entire arm is paralyzed, the same treatment principles should be followed. Gentle massage and range of motion exercise might be started by 7 to 10 days of age, and infants should be closely monitored with active and passive corrective exercises. If the paralysis persists without improvement for 3 months, neuroplasty, neurolysis, and end-to-end anastomosis and also nerve grafting of the problem hope for partial recovery. The type of treatment and the prognosis depends on the mechanism of injury and the number of nerve roots involved. The mildest injury to the peripheral nerve is called neurapraxis, and it is caused by edema and heals spontaneously within few weeks. Axonotmesis is more severe and is a consequence of nerve fiber disruption with an intact myelin sheath, and function usually returns in a few months. Total disruption of the nerve, which is called neurotmesis or root avulsion, is the most severe, especially if it involves C5 to T1. Microsurgical repair might be indicated in this case. Fortunately, most injuries are at the root level, that means at C5 to C6, and it involve neuropraxia and axonotmesis, and they should heal spontaneously. most of them are not due to total disruption of the nerves or neuroatmesis. Botulism toxin might be used to treat biceps triceps co-contractions. This is all about brachial injury. Thank you for watching.